Hello everyone. Today we will discuss about dengue as an essay question. So dengue is an arthropod-borne viral infection caused by dengue virus which belongs to the family flavivirus. It is transmitted by Aedes mosquitoes. It is characterized by fever, myalgia, rash, thrombocytopenia and vascular damage. Sorry, leakage. So coming to the epidemiology, it is caused by dengue virus which is a flaviviridae which belongs to the family of Flaviviridae and an RNA virus and has four serotypes. And humans are the major reservoirs. It is transmitted by Aedes aegypti. Mode of transmission is through the bite of an infected mosquito. Incubation period is 4 to 10 days. Common in India in post-monsoon period. So this is the Aedes aegypti mosquito. The determinants include the viral serotype, then virus 1 to then virus 4. So the severity varies with the serotype. A secondary infection with a different serotype increases the risk of severe dengue due to the antibody-dependent enhancement. The vector Aedes aegypti and Aedes albopictus is highly adaptive to urban environment, breeds in clean stagnant water in artificial containers. The vector behavior is day biting habit, indoor resting, and multiple bites during one feeding period enhances this transmission. Overuse of larvicides or fogging agents may reduce vector control effectiveness. Coming to the host factors, children and young adults are more affected. Males are more affected due to the exposure to outdoor activities. Low socio-income groups have poor housing, waste disposal, and water storage practices, leading to increase in contraction of dengue. Lack of knowledge about mosquito breeding and prevention practices also increases the risk. Outdoor workers, construction laborers, market vendors have higher exposure to Aedes bite, leading to increase in susceptibility to dengue. Storage of water in open containers, use of ornamental plants, religious water rituals creates breeding habitats for dengue. Migration and travel introduce new serotypes and spread infection to newer areas. Coming to the environmental factor, rapid urbanization, climate and rainfall change, water storage and sanitation practices, solid waste management practices, and pre-existing public health infrastructure. Low community participation in trade activities and awareness campaigns reduces prevention success. So climate change and globalization are the major key factors in the determinant of dengue to Flaviviridae and Flavivirus genus. And it is a positive sense single stranded RNA virus with 11 kb genome. It is an enveloped virus with a lipid envelope derived from host cell membrane. The structural protein consists of two proteins, E and M. E enveloped virus, which mediates attachment, fusion, and induces neutralizing antibodies. In the membrane side, there will be a structural role stabilizing the envelope. Coming to the non-structural proteins, there are two, NS1 and NS3 and NS5. NS1 is used for diagnostic testing through antigen detection. NS5 and NS3 are involved in viral replication. Type 1 provides lifelong immunity to the same serotype, usually causes the classic dengue fever. The type 2 also causes lifelong immunity to same serotype, commonly associated with severe dengue. Though in dengue virus type 3, it may cause severe outbreaks and it also provides lifelong immunity. In fact, all the dengue virus causes lifelong immunity for that serotype, and in case of 4, less severe primary infection. So coming to the cross immunity between serotypes, temporary cross protection lasts only for a few months. Subsequent infection with a different serotype risk antibody dependent enhancement leading to severe dengue or shock syndrome. The cellular target. Monocytes, macrophages, and dendritic cells are initial sites of viral replication. Cytokine storm causes vascular permeability leading to endothelial dysfunction. So primary infection usually will be a mild febrile illness. The secondary infection there will be pre-existing non-neutralizing antibodies that enhances the viral entry, massive cytokine release leading to leak capillary syndromes. In liver, it causes fatty change, necrosis, and elevated transaminases. In spleen, it causes congestion and lymphoid depletion. In the bone marrow, there is hypocellularity with the suppression of megakaryocytes leading to thrombocytopenia. In the vessels, there will be endothelial swelling, perivascular edema, and plasma leakage. Coming to the lungs, there it will cause pleural effusion and pulmonary edema. In the brain, rarely it causes cerebral edema and encephalopathy. Coming to the clinical features, in the febrile phase, there will be high fever, high myalgia, and rash. The critical phase, there will be plasma leakage and warning signs. In the recovery phase, there will be fluid reabsorption and rash fades away. So, in the febrile phase, there will be sudden onset fever, severe headache, mouth and nose bleeding, muscle and joint pain will be there, vomiting will be associated, and there will be rash and diarrhea. Critical phase, there will be hypotension, pleural effusion, ascites, gastrointestinal bleeding. In the recovery phase, there will be altered level of consciousness, seizures, itching, and slow heart rate. Coming to the diagnosis, through NS1 antigen in ELISA technique detects the non-structural protein type 1 of dengue virus. It is usually detected in the window period of day 1 to 5 of fever, indicates active infection, useful in early diagnosis. RT-PCR also can be done in day 1 to 5. It is gold standard for confirmatory test, useful in research and outbreak investigation. It usually detects and amplifies the viral RNA, allowing for serotyping also. IgM ELISA can be found from day 5 onwards, appears during convalescence and confirms recent infection. It detects the dengue specific IgM antibodies. IgG ELISA detects IgG antibodies after 7 days, indicate past or secondary infection. Rising titer confirms this. Type 1 indicates dengue without warning signs. Type 2, dengue with warning signs. Type 3, there will be severe dengue hemorrhagic fever or dengue shock syndrome. So, what are the warning signs? Abdominal pain, vomiting, hepatomegaly, bleeding, and restlessness. Coming to dengue shock syndrome, there will be cold, clumsy skin, narrow pulse pressure of less than 220 millimeter per mercury. Hypotension will be there, tachycardia will be there, and oliguria. It requires urgent fluid resuscitation. Dengue in children. It is often non-specific with fever, rash, and hepatomegaly. Shock develops early and there will be convulsions. Dehydration is also quite common. Higher risk for complications in secondary infections. Dengue frequently presents as pyrexia of unknown origin in tropical region, prolonged or biphasic fever, rash, thrombocytopenia, and elevated liver function test. Differential diagnosis include typhoid, malaria, leptospirosis, chikungunya, and scrub typhus. Coming to the investigations, the CBC shows leukopenia, thrombocytopenia. There will be greater than 20% of hematocrit rise. LFT rise to AST and ALT. In ultrasound, there can be ascites or pleural effusion, gallbladder edema also. Serology, NS1, IgM, IgG, ELISA, and RT-PCR are useful. Coming to the management, there is no specific special treatment for dengue. Mainly, it is through supportive care. There is no specific antiviral. Outpatient oral fluids, paracetamol, and monitoring is required. In case of inpatients, there will be IV requirement for IV fluids, but we have to avoid overhydration and transfuse only if there is any active bleeding. Coming to the fluid management in pediatrics, crystalloids are preferred, colloids only in refractive cases. Monitoring the urine output, vitals, and hematocrit every 4 to 6 hours is essential. Coming to the complications, hepatic failure, myocarditis, renal failure, encephalopathy, DIC, and mortality up to 20% without treatment, but less than 1% with care and treatment. Differential diagnosis include chikungunya, malaria, typhoid, leptospirosis, strep typhus, and COVID-19. Prevention and control. So, vector control acts as the main source of prevention with that should eliminate breeding sites, larvae sites, and fogging. And personal protection, application of personal protection through repellents and nets. Weekly dry day and IEC campaigns. Surveillance via IDSP, IHIP, and National Vector-Borne Disease Control Program. So it is a part of the National Vector-Borne Disease Control Program with malaria, chikungunya, filariasis, JE, and Kala Hazar. Focus on vector control, early detection, and case management. So in PUO evaluation, suspect dengue in endemic zones with thrombocytopenia and raised transaminosis. Repeat NS1 and IgM ELISA after 5 days if initial test turns out to be negative. It is excellent recovery in uncomplicated dengue. Even in case of severe dengue, fatality is less than 1% with appropriate fluid management. So, to summarize, dengue is an active mosquito-borne viral infection caused by flavivirus. It is transmitted through Aedes aegypti mosquito. It presents in 3 types: dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. The disease rapidly progressed through a febrile phase with a sudden fever, headache, myalgia, and rash. A critical phase characterized by plasma leakage, thrombocytopenia, abdominal pain and bleeding. Recovery phase with gradual reabsorption of fluids and clinical improvement. Laboratory findings include leukopenia, thrombocytopenia, and elevated hematocrit. Management is largely supportive, focusing mainly on hydration, oral or IV fluids, monitoring the hematocrit and urine output, avoiding NSAIDs and aspirin. In case of severe cases that require hospitalization, there should be judicious fluid therapy and blood transfusion only when indicated because of active bleeding site. With early intervention and proper fluid management, dengue has an excellent prognosis and low case fatality rate. So, dengue is preventable and manageable. Early recognition, fluid therapy, and vector control are most emphasized. Consider dengue in a PUO, and community participation ensures control. I hope you have learned through this video. Thank you.